So I've been given the job of talking about Achilles repair. Is stretch out of the repair consideration for return to play. I do, unfortunately, have nothing to disclose financially. When I talk about, it's an honor to be invited back to talk at this symposium. I want to thank Mal and Janet for all their efforts putting this together, and obviously Northwell Health. I fortunately had the opportunity in my first few years of practice here at NISMAT to interact with Dr. Nicholas Sr. It was truly, to have somebody of that magnitude be in the clinic. At his last final years, he didn't see a whole heck of a lot of patients. He would just come in for a couple hours, see a friend or two, and then he would come upstairs. Steve would probably kick him out of the office. He'd go upstairs and he'd sit in the rehab PT department and he would grill us and he'd watch what we were doing, So as scary as it was back then, I know it made us all better clinicians, and it's truly an honor to have the opportunity to work with him. So to talk about this, we're going to talk a little bit about Achilles tendon ruptures, some of the history of tendon elongation if you're not familiar with it, some of the clinical implications of tendon elongation, and then some of the clinical keys that we use at NISMAC to address this. Many of us have treated Achilles, obviously. They're more common in males, more common in the athlete. Usually the third or fourth. We're starting to see more in the fifth decade, I would say now. There's an increase of contralateral side ruptures. And then if you are Hungarian, or if you're Finnish, if there's any of you in the room, if you're blood type O, you have a higher incidence of trying to, of rupturing your Achilles, so be careful. Ardner and Lindholm back in 1959 set forth 3 different ways that we can probably rupture our Achilles, and the first one is the most common, and that is what we see every day when we watch NFL or we watch basketball. That's the push off from when the weight bearing forefoot while extending the knee, so jumping, sprinting. These are the most common ones we see. Sudden unexpected dorsiflexion of the ankle, such as slipping in a hole or falling downstairs. I've had a few of those, but those aren't as common. And I've never seen anybody set this forward is violent dorsiflexion of a plantarflexed foot. Whether they do non-surgical or surgical, more commonly we see surgical, and these are typically open repairs from my experience. There's various techniques out there based on where you practice, different types of support, epitendinous weaves. There's percutaneous repairs, and then finally I've never seen any but the fibrant sealant. I think that's a little bit bigger in Europe. But regardless of what procedure, the end goal really is to return back to sport for most of these, because most of these are going to be athletes. And this study just came out actually just this year in BJSM. It is a systematic review and meta-analysis, and I know how much Mal enjoys or not enjoys systematic reviews, but the interesting thing here is they had 108 studies. Only 85 of these actual studies included some sort of return to play criteria. And so if they looked at all the studies, only 80% of people actually get back to the level that they want to get back to, which is, it sounds high, but if it's still an odds game I wouldn't want to play. Some of the biggest things here are, when you look at these meta-analysis, is what sport are they playing, what level are they playing, are they professional athletes, are they high school athletes, are they college athletes, and then how long did it actually take them to get back. These are all things that are a little more interesting and we need to know. So if we look at this recent NFL study that just came out, they looked at all of the outcomes of orthopedic surgeries and how they returned. And of all the orthopedic surgeries, 79% of actually athletes returned back to play in the NFL. If they had an Achilles rupture, you can see here and how it scales out with the rest of them. If they had an Achilles rupture, only 73% of them actually returned back, and which is one of the lower percentages. You can see ACLs are 82, patellar tendons obviously were the worst of all of them. And interestingly enough, with the Achilles, you can see here is from the year they ruptured, this is the 1 year out, their productivity and their performance and the amount of games that they played were significantly decreased in that first year. They never really got back up to where they wanted to get back up to. If you look at their return to play, the average return to play was 375 days, right? So we're talking a year. And the average length of an NFL career is 6.3 years, according to what you read. And then the average career after an Achilles rupture is 1.6. So obviously it significantly decreases your average age. And that's probably why this is Arian Foster, if you're not familiar, he's an 8-year player who just retired last week after rupturing his Achilles last year, and he must have looked at these numbers and decided this probably isn't, the odds game is probably not in his favor, so he went against it and retired. So what does Achilles tendon elongation have to do with return to sport? So if we go back, all the way back to 1983, there's a study by Nystrom and Holland, which was a rabbit study. They incised the Achilles tendons, and they sutured them back together, and they watched it over time. And this was the first time we saw what's called a biphasic elongation. So this is when they fixed it over time, over the first few days. It started to elongate, it stabled out, and then it elongated again. If we go to the Mortensen study is a suturing study that looked at 2 different suturing techniques. And then what they did the same thing is they looked at the tendons over time, and they had a biphasic separation as well. It didn't matter what suturing technique, the elongation still happened. So if you ask how do they do these elongation studies, what happens is when you have surgery, they actually put these little metal beads in. We don't see these very often, but they put little beads in, and then over time they x-ray them, or they probably CT scan them. And then what they do is they take that measurement, and then they take that measurement incrementally, and what they'll do is they'll see how much of these things separate over time. So if we continue to look at this, we could see here in Mortensen in '99, same thing. This was a delayed versus a mobilization study in Achilles repairs. And once again, these guys saw elongation of that tendon by 12 weeks. Oops, sorry. And then the same thing in Kangas. Kangas showed the same thing. He showed elongation from the onset of surgery all the way to the end. So the tendons were elongated. So the one thing we see that's interesting with all 4 of these studies, if we look at them, is all 4 of them, if we go out to about 12 weeks, all of them about 12 weeks, that's usually where they level off at, and that's where they stop elongating. And they're all elongating somewhere around 10 to 12 millimeters. So this is kind of where we come up with, and we'll talk about a little bit later, is we try to stop, we do not encourage stretching before these 12 weeks because we feel that we are encouraging this elongation by stretching these Achilles tendons early on. And so if you go back to the Kangas study in '06, this is the first study that probably the only study that I've seen that actually correlated this elongation with poor clinical outcomes. So they found that there was a poor clinical outcome with the increased tendon elongation. So those patients who had greater elongation had poor clinical outcomes based on an Achilles rupture performance score. And what really sparked their interest too is the Mortensen study in '99. They actually looked at strength, and they looked at strength in a 15-degree dorsiflexion angle, and they looked at it in a 15-degree plantarflexion angle. And what they found, this didn't matter what group they were in, what kind of motion they did, they had a significant 25% deficit at 15 degrees of plantarflexion. But if you put them at 15 degrees of dorsiflexion and really had them contract, they only had about a 10-degree deficit, which, you know, at 8 months you wouldn't think would be too terrible. So what we say is, what does elongation have to do with us clinically? I say if you have any Achilles patients now who are pretty far out, put them in these 3 tests. Try these 3 tests, and you're going to kind of let us know what you see. Because based on the previous studies, we did a study in 2006 we published to determine if patients have selective muscle weakness in end-range plantarflexion following Achilles tendon repairs. So our inclusion criteria would have to be at least 6 months post-op, unilateral injury, satisfied with their outcomes, it had to be an acute injury. Our patients, we had 19 patients total, majority obviously were going to be male, average age of 40. The surgeries were open-ended repairs, and the rehab was pretty standard, 4 weeks, non-weight bearing, dorsiflexion, active dorsiflexion, 2 to 4 weeks, 3 to 4 weeks start of PT, and your standard rehab protocol. And then we did isometric plantarflexion testing, which we put our patients in a seated position, knee in full extension, and we had them do 3 different contractions at these angles. So 20 degrees of plantarflexion, 10 degrees of plantarflexion, neutral, 10 degrees of dorsiflexion, and 20 degrees of dorsiflexion, and we recorded their peak torque. We also looked at dorsiflexion range of motion, and we looked at the change in passive torque from 10 degrees to 20 degrees of dorsiflexion. We put them through our series of functional tests. This is our toe walking test, where we just have them walk on their tippy toes down the hallway, and you can see the decreased drop on that right side heel. And then we put them through our 3 heel rise tests. So first we put them on the floor. We have them do a plantarflexion heel rise on the floor. We put them on an incline up the hill, and then we put them on a decline so they're in that plantarflex position. And then we grade them as positive, being impaired, or negative as being normal. And this is an example. So if you see, this is a non-involved side. This is on the decline. So this is a 20-degree decline angle. You can see his non-involved side. And then you can see what you put him on the decline angle on his involved side. He has no ability to plantarflex. They typically use a knee-jerk mechanism to try to act like they're actually going off, but they're really not going off. But you can see it's not that he doesn't lack the motion. If you put them bilaterally, they don't have a problem getting it. It's just that they have that end range weakness functionally. Here's another example. This is the non-involved side, no problem. Involved side, you can see he puts his toe down to try to fool me, to think he can really do a heel rise. which he really could not do a heel rise without that. And then you put him on the incline rise, and you can't really tell the difference from one side to the other. I can because I know who it is. But they tend to they go about the same height. You really can't tell which one is the involved and which one is the involved. They really have that ability. So what we found is that when we put our patients in this 10-degree plantar flex position, they had significant weakness, up to 20%. And then if we put them in a 20-degree plantar flexion, it was up to about 35% deficit from side to side in that end range plantar flex position. We also had a significant angle to torque relationship. So we went from 20 degrees to 20 degrees. In that 10 and 20 degrees, there was a significant drop off over that period of time. If we look at our functional tests, we had no dorsiflexion range of motion deficits, but what we did find, which was interesting, is that our involved side had 34% lower stiffness or passive tension in the repaired side versus the non-repaired side. So if we look at our functional tests, so our toe walking, the green is the involved, the yellow is the non-involved. So on the involved side, the toe walking, 14 of 19 could actually do it. 19 out of 19 could do it. If we went on the incline, 19 of 19, they all could do it. If we went on the neutral heel rise, 16 of 19 could do it. But if we went on this decline heel rise, you could see only 6 of our 19 patients could actually perform this activity to what we considered normal. So what we found is that end range plantar flexion weakness at 10 and 20 degrees. Our passive joint stiffness was 34% lower on that involved side, and we have significant loss of functional end range plantar flexion strength. So at the time we thought, well, there's a couple things this could be, right? We could have anatomical lengthening or stretch out. The journal would not let us write that because we did not put any of those indwelling markers on, so we had no way of justifying it. It was really elongation. Could it be increased tendon compliance, or could it be just our rehab just wasn't up to stuff? Maybe we weren't doing the right things. So we thought, like any study, how can we improve this? So we went back and we redid it again. All right, and so 2 things we wanted to focus on: could we make stronger repairs with epitendinous augmentations, and could we avoid post-operative passive stretching for 12 weeks? So if we did this with all our patients, we repeat everything, let's actually see what happens. So we just actually submitted it to AJSM summer meeting for this summer. So we had 18 patients, did all the same tests, isometric. We did passive tension, functional tests. This time we just added EMG activity as well as tendon thickness measurements. And what we found, unfortunately, is we still had significant end range deficit. So 20 degrees of plantar flexion was now at 27%, which was better than it was, but still a significant deficit. At 10 degrees, we were at 17%. Only 3 of 18 could perform this heel rise on a decline. We had no difference in EMG amplitude, and our passive stiffness was now similar. We didn't have a 34% deficit, and we did have a decrease in dorsiflexion range of motion, and the thickness of the tendon was 7 millimeters greater. So despite trying to alter the surgery and rehab, we're still obviously lacking some end range strength. So if we look at the main findings of our second try here, right, we think there's not really a neural inhibition in the muscle because the EMGs were pretty normal from side to side. We had normal passive joint stiffness, which we probably think that's from not stretching them. So we didn't stretch them, so their passive stiffness is probably still the same side to side, unlike our previous study. So all in all, we think that inefficient transmission of contractile forces. So now we have a thick tendon, we have a muscle in a shortened position that's probably still elongated. So these are the reasons why we're having this issue. So the question why we're all here, right, is tendon elongation a concern for return to sport following Achilles tendon repair? And if I look around the room that, I know myself or many of us washed up athletes, I don't really think that this is probably not an issue. I don't think you or I or any of us in this room would really notice it. Because none of our patients usually notice it unless we put them in that position. But I think if you look at the more high-level athlete, whether it's a college athlete, you think of the positions, you look at somebody who's doing it dancing for a living, the angle of plantar flexion they must jump off of and land in. You get a Simone Biles who has to go in that deep plantar flex position, you go into a layup, you're probably going to have an issue, and they will probably notice, and especially if you look at runners, right? So runners need to go in that plantar flex position. They need to push off, they need to explode off. So they're probably going to report some sort of loss of step in their career. So they're probably not going to get back to the same level as they did. So one of the interesting things, if you look on the right hand, this is the non-op side, this is the op side, and this goes back to our ACL work, and I don't have volume to this, but this is more of a volume thing than it is a visual thing. But if you have your patient do a vertical jump just up and down, and you can almost see it in this video, is on the right side, he has a little bit of spring to his jump. You'll see he'll bounce up and down, he'll bounce up and down. If you go to that left side, besides him being all over the place, they don't have the ability to stop that heel from hitting. So every time you'll just keep hitting, you'll keep hearing that slap, you'll keep hearing that slap, keep hearing that slap, and that is most likely probably because they don't have the ability to eccentrically control in that plantar flex position because they lack that strength. So it's something to look for in the clinic when you're treating these. So clinically, what can we really do clinically to address these? One of the basic things we do right off the bat is we minimize Achilles tendon adhesions and scarring. And this is by the simple active dorsiflexion and passive plantarflexion. I mean, we do this as soon as we get our patients to try to mobilize that tendon. And pretty much learn this from Dr. Lee and his hand work, right? So develop a strong repair from our hand surgeries. We'll decrease soft tissue adhesions, and then we'll promote proper scar formation by just doing that active mobilization. Secondly, what can we do is do not assist in Achilles tendon elongation. So try to delay passive stretching for up to 12 weeks. That's kind of what we follow now. And so this is obviously a right-sided, this is 3 weeks post-op, prone position. There's not much science here, it's more just art, right? And then by 9 weeks, this is not stretching this patient. This is just by him standing, walking, living his life. You can see him in the plantar flex position. All of a sudden, he's back to neutral. And this is probably an example of just the passive elongation of the tendon over time. So I don't think we need to stretch him, and I don't think it's something that we need to stretch that early on. So one of the things one of our fellows did, we want to protect the repair as well early on. And so Dr. Akazuki showed us that if we put a 1-inch heel lift, we'll decrease the EMG activity of the gastrocsoleus muscle by up to 57%. A ½ inch is going to drop it in half to 22%. So something that we use is a graduated weight-bearing system or graduated heel lift system where we'll use peel away heel lifts, and over time we'll start them with maybe a ½ inch or 3/4 inch, and then over time we will peel layers off, layers off, layers off. So we are not helping that elongation, we're trying to minimize that elongation by stretching it. The other thing we can do is monitor clinically elongation and function. So one study that just came out a few years back in 2013, and this was the Achilles tendon resting angle. And this is a way that they showed us we can try to objectify Achilles tendon elongation. And it was found to be clinically indicative of joint stiffness and tendon elongation. So like 10 millimeters of elongation equals 10 degrees of dorsiflexion. And simple enough, this is a pretty simple test we can all do, is we put them prone, 90-90, and all we're doing is measuring their mid-fib shaft to the base of the 5th met. And essentially you're just taking a dorsiflexion range of motion from a different position. And it's a side-to-side measurement, so you're going to see the side-to-side difference, and you'll see if there's elongation happening on one side versus the other. Earlier on, it's probably going to be the opposite. They're probably going to be in a plantar flex position, but over time you're going to see that elongation. Another thing we can look at is Cybernagel showed this in 2012, the heel rise test. So they had single foot heel rise on a 10-degree incline. They were instructed to go as high as possible, and they were terminated when they can no longer do it. They were supposed to go about 30 heel rises a minute, and they taped them so they could see how high they were going. They also did Achilles tendon elongation length testing via ultrasound, which is the other technique, and they looked at their outcomes. And some of the interesting things here are, the baseline is that 44%, there was a 44% deficit in heel rise height at 6 months and a 32% deficit in heel rise. And they correlated that with, you could see their heel rise height to their Achilles tendon elongation. So you could see the injured side was 23 at 6 months, and heel rise was only 7.8, where the uninjured side was a 20, and then it was up to a 14 was the heel height. So it's another way we can try to objectify it, and we can see if that strength, the elongation, is impacting the strength. And then finally, another thing I think we should do on a regular basis in the clinic is give them these Achilles tendon total rupture scores. Right? This study showed us that at 3 months, it's predictive of a 1-year outcome return to sport. So if we can give these things, much like Tack was talking about before, if we can give these earlier in their rehab and get a better idea if they're falling behind, if they have a lower score, maybe we need to change something, or maybe we need to pick something else up in the rehab, then it's something we should do. So it's another score, another objective things we can do in the clinic. And finally, what we can do too is we try to focus on end range plantar flexion strength. We focus a lot of time on plantar flexion strength, but we don't really work in that end range. So this is just an example, and this is typically how we start. We start them in a plantar flex position bilateral, so they're getting that feedback. This is obviously his involved side. And we start working in that plantar flexion end range. Because you think about it, there's probably not many of us that work in an end range position. We just say, okay, do calf raises, do calf raises. You're not actually objectifying to see how high they're going. So different things we do in the clinic, we have reformers, so we don't let them go past neutral. We just work that neutral to plantar flex position. Obviously, you can change the strength, or a total gym you could do this on. You can change the forces. We'll put them in a plantar flex position. We'll have them do kickbacks, so they're going to work a little bit of gastroc as well as their soleus. But same thing, most importantly, is that they can hold that end range. If you go on the leg press, if you just put your leg on the leg press platform, it's probably in a plantar flex position, so don't drop them down bottom where they're going to just stretch out and then go up on a plantar flex position. Stick them on the platform, see if they can get their heel off the platform, and then finally we'll work to a more inclined position. We'll go on to our slant boards. This is about a 20 degree angle, and if not, sometimes we'll use a towel roller. We'll start them at a lower angle and then try to work them up to a higher angle at some point. And then what we'll do is we'll work on our eccentrics. So I don't have her other side. This is actually her involved side. So we'll have her plantar flex bilaterally and then just do the eccentric drop, because she really has a tough time just doing multiple concentric plantar flexion in that particular position. So we'll actually do the up with 2, shift over to the involved, and then just come down on that involved, and we'll work on that end range plantar flexion that way in an eccentric component. So in conclusion, if you weren't familiar, Achilles tendon elongation is a real thing. There's plenty of documentation out there. I think it's something that we do see clinically, or it has seen you and you haven't not seen it. We do lack force transmission capability, and that's probably because of the thick tendon muscles now in a shortened position, and probably as a poor lever arm because of the elongated tendon. So it's something we need to consider. And then clinically, what can we really do, are the things we talked about, right? Minimize scar formation. Early active mobilization is an important process here, especially in the early stages. Resist the urge to stretch. I know it's a very difficult thing to teach somebody, or especially a therapist, not to stretch an Achilles tendon, because we all feel like when they come out of that, they're so tight, we need to get their range of motion back. But I've talked to plenty of therapists and have treated plenty of these, and I have never, ever really had a patient lose dorsiflexion range of motion. I know we saw it in our last study, but it's typically not a functional deficit, so they don't even know it. And then monitor that elongation. So do some of those the passive elongation tests. You could do the heel rise test. These are all tests that we can do clinically to try to help, because I don't have an ultrasound in our clinic, or I don't have the ability to do CT scans or any of this. And then really try to add this. I think a lot of people miss the end range plantar flexion strengthening portion of the rehab. I think really focusing on that end range is probably one of the keys to try to get all of that strength back. So with that, I want to thank you for your time, and if anybody has any questions on.
Any questions? Yeah, Mike, I have a couple of questions. I took some notes. You showed the video of the impaired heel rise test, or on the decline, and you can see the patient jerking when they're trying to do the test. Now, you assessed the patients in the study in 2006, and Carl Arashimo assessed the patients 10 years later, so there's not necessarily a clean agreement between how you assess it. But we saw the same thing. The patient jerks their knee to try to get up to do the... What if it's not a very convenient thing to do, what if we put the patients in a drop-lock knee brace?
I was thinking the same thing we were saying.
If we put them in a drop-lock knee brace, would it increase the sensitivity of the test, and we'd find true positives?
Yeah, I don't know. I was just thinking the same thing as you were saying that question. Yeah, you would definitely. I think they're, and I don't know why they do that. I don't know if they're dropping down and trying to use more soleus, or they're just trying to use their momentum to try to get up. But yes, I think if you lock them in a knee brace, I think, yes, your sensitivity to test, I think, would probably be better than it already is, and I don't think they'd be able to move.
Yep.
What if you get someone 4, 5, 6 months post-op, they went somewhere else first, and they're sent to you to clean up their mess? What's some strategies that you have?
I would go to all the clinical stuff we talked about. I'd try to take that passive measurement and see if you think they're elongated, which they probably are going to be, because they probably got stretched. And then I think the other thing is that end range. I think that end range strengthening is something that, I know I lacked it for a large portion of my career until we started to really look at this and actually see how big the deficit was. But I think that is the end range strengthening is probably really, really key because, you know, where's Mike? I was talking to Mike in the back yesterday, and do you mind if I share the story, Mike? So Mike had a patient, an Irish step dancer, so professional. And so she had an Achilles repair and she had this end range strengthening, and she was so committed to getting better that she traveled from New Jersey a couple times a week to see Mike. He worked the end range strengthening, or one of his other therapists, to work the end range strengthening, and she was able to normalize it. So I can't say that we've seen anybody long enough, and I can't say that we can stop it or gain that strength back. I don't know the answer, but I know.
Did she not stretch till 12 weeks?
What's that?
Did she not?
I don't know that
stretch
answer.
till
You'd
12
have to, probably.
Did you not stretch her till 12 weeks?
No, we didn't get her until a year out.
Oh, wow.
And she was already stretched.
So they were able to reverse it by doing all this end range strengthening and really focusing on an end range, and I think that's a key component. And that she had the commitment to do that. I mean, most patients don't have the commitment to do that. So.
You're not going to tease it with your new data from how you changed the whole rehab protocol you just showed us?
Did you watch the presentation?
No, I was working on my slides.
Yeah, well, your slides are all messed up. So I had one more observation, comment, question, was you showed a slide showing how poor the return to play rate is for Achilles tendon repairs, and you showed that ACLs were better. But, you know, that's comparing apples to oranges. If you looked at the average age of when the person tore their ACL versus the average age of when they ruptured their Achilles, when you rupture your Achilles, you're older, you're at the end of your career, and you're as likely for your career to end by just coming to the end of the season without an injury as an Achilles. It's just the little thing that pushes you to, you know what, I'm going to retire. At the professional level, at the amateur level, it's the same way. It's usually your wife tells you, you know, it's time to give it up, guys. But you can't compare it because the average age of the ACL tear is different. And our return, all through today, there's been return to play percentages. Not one person has provided if you take a sample of 80 patients that had ACL reconstructions in the NFL and how many of them got back to play 3 years later. If you took a sample of the same number of people who did not have an ACL tear, about 20 to 30% of them will not be in the NFL 3 years later because the careers are short. So I think we're not doing ourselves justice.